Sure. So I gave a talk discussing how comorbidities can impact the choice of therapy, and I was tasked with specifically focusing on the combinations of BTK inhibitors with BCL2 inhibitors. So I started my talk by acknowledging in the US we don't currently have an approval for such a therapy, as I plus V was not approved in our country. However, we do have a lot of combinations that we may see approvals for in the future. The most close one may be an approval for acala plus venetoclax, but I also spoke about some ongoing studies such as the phase 3 CELESTIAL-TN study looking at xannuance and rotoclax. And so when thinking about how comorbidities play a role in our therapy decisions, with the use of a BTK inhibitor, I always think about, is this a patient who is too high risk to be able to sustain this therapy even for a fixed duration of time? I think that is the beauty of these combinations, is they're not indefinite therapies, they're time limited. However, patients with severely high cardiac risk, I may have pause before using these drugs, or also patients with a severely high bleeding risk that's expected to continue throughout the duration of therapy. With the BCL2 inhibitors, we also have to think about the inconvenience that can be posed by the tumor lysis monitoring, and also some of the other unique side effects that come with these therapies, such as neutropenia, and then the risk of tumor lysis, which is obviously dependent upon when the agent is given and whether patients have been debulked. Nonetheless, I did conclude by saying that for patients who are interested in such time-limited options, I do think most patients are candidates. I think absolute contraindications are pretty uncommon, but I think in the end we do have a lot of options that work quite well, and it comes down to the individual patient discussion that often weighs not only their comorbidities but also their preferences.